of Virtual Morning Report with Prof. Rez and our very special guests. So this is a little personal for me. So I went to medical school at Brown, and the director of my sub-I, Dr. Arkady Finn, who I immediately recognized was very unique amongst many teachers I've had in his passion for pure clinical medicine. And as you know, that's basically what Reza and I do, and that's in large part due to people that guided us along the way. And so I'm excited that Arkady is here with us today, accompanied by his colleague, Vijay, who is now the current director of the sub-I at the rotation. So before I pass the mic for them to introduce themselves and add a little bit more color to that introduction, one of the big reasons that our paths crossed again is something that I really want to emphasize to you all today. So these incredible people actually started the Brown Journal of Hospital Medicine. And when I pass the mic to them, I'll put in the link into the chat. It is an incredible clinical journal with really, again, focused on what I saw to be Arkady's passion, which is clinical medicine. They're especially unique because they're one of a few journals that actually have a CPC, CPS style entry in their journal. And that's, of course, my favorite thing in the world. So I saw the first case and read it, thought it was incredibly well written. And that prompted reaching out to Arkady and the session that you're seeing today. So welcome, it's a delight to have you here. And I will emphasize over and over again, you all have to check this journal out. It's very educational. But I'll pass the mic to you guys to say a quick hello.
Ravi, thanks for the kind words. We are very excited to be on Clinical Problem Solvers. We've been aware of it. We've seen you all on Twitter, and I'll be honest with you. I know you were introducing. I'm a little bit starstruck right now. So Vijay is the editor-in-chief, and we're both at the Miriam Hospital in Providence. The reason we started the Brown Journal of Hospital Medicine is because we, in hospital medicine, which I'm sure most of you folks are aware of as a specialty, there's really only one other journal in the field, and what is published in that journal is probably a bit too high level for clinicians, like I'm sure most folks are on this call or on this podcast. I'm showing my age. So we decided to kind of take it in our own direction, and we encourage everyone to submit, your case reports, your QI, your research. We'll review it, we'll send it to peer review, and we'll kind of keep it growing from there. So Vijay, you want to add anything?
Oh, I agree with everything Arkady said, and it's very nice to meet you all. Looking forward to your submissions. Check out the website. Reach out to us if you have any questions. We'll be happy to answer them.
And now we're looking forward to presenting this case to you.
I know, what better way to illustrate that? By the way, it's a record today. It's been 8 minutes since we started the call, and Prof. Rez hasn't said a word interjected or interrupted. Wow, you all make note of that. It's a special day.
And then to add on top of that, as I'm trying to unmute myself, it's not working. I'm like, get unmuted.
Prof. Rez, it's a delight to see you today. And I'll pass the mic to our team to share the screen and jump on in. All right, Arkady and Vijay, we're ready whenever you are.
All right, very good. So the chief complaint was fever, cough, and sore throat.
Wow. I think, is it okay if we stop here and do a quick reflection?
Yeah, it's your show, I think.
Awesome. I'll be very brief here. We don't have an age or a gender, but I'm used to this because on our RLR Patreon podcast, Robbie usually hides both of those epidemiology clues from me. But the reason I wanted to stop here is because you can already gather so much information from these 5 or 6 words. The fever is telling you there's inflammation. We need the tempo of that inflammation, but I'm going to assume acute for now. So acute inflammation means infection. The cough and sore throat, really you focus on the sore throat, and what rises to the top of the DDX is a pharyngitis, though we're open to other processes presenting with sore throat. So just from these words alone, my mind is already putting a lot of weight on the fever of inflammation. likely infection with an oral pharyngeal source.
All right, so we'll keep going, yes? All right, so this is a 64-year-old female with past medical history of COPD, anxiety and depression, and a previous history of pneumonia, who is coming with 1 week of fever and chills, rhinorrhea, cough, and sore throat. She describes it as kind of URI symptoms, clear discharge, but then she started to develop a headache, a little bit of breathing difficulty, and some cough, which was initially non-productive, but then became productive, of clear sputum or whitish sputum. The temperature that she's had at home was as high as 103.8. And it was associated with, back pain, myalgias, and kind of diffuse pain in her joints.
Ooh, I think that literally the temperature in this room just went up because of how high the fever is. And I think that the real tension in this case is that we're very used to superficial infections causing problems. So when patients get a superficial skin and soft tissue infection, when patients get pharyngitis, or when patients get a distal urinary tract infection like cystitis, that's very common. And that's what the first line reads. She has a little bit of chills, rhinorrhea, and a cough, but all of a sudden, those benign hypotheses go out the window when the patient is that febrile and then has lower respiratory tract symptoms with the dyspnea. And so you can see that this disease process is literally going in deeper and deeper into her body. And the question is really fundamentally, is this a biphasic disease process? Like, is this something that began as a mild pharyngitis that then extended to something more sinister? Or is this merely chapter 2 of a slowly evolving story? And that's actually very hard to tease out. So, I think what we know for a fact is that this patient is not the usual pharyngitis. And the biggest reason is because that she has lower respiratory tract symptoms and she has systemic features. So the question is, did she have a complication of pharyngitis, like a suppurative complication, like Lemierre's or a peritonsillar abscess, or merely does she have lower tract involvement of the original disease process? And so I think that's the fundamental analysis. And the question is, how much do you make of each individual symptom? Do you say that the headache actually is suggestive of a CNS disease process? Do you say that the myalgias and arthralgias are localizing to the muscle and joints? Or do you just simply step back and say, I know this patient has a deep inflammatory process, and by virtue of the acuity, likely infectious? And I think that the reason I would stay broad is because headache, myalgias, and arthralgias are notoriously false localizing symptoms, meaning that they ache simply because of a systemic process rather than a disease process that lives within each of those spaces. So that's my reflex reaction, but I would study to make sure that the headache doesn't feature meningismus, that the myalgias don't feature weakness, that the arthralgias don't feature an arthritis, which would change the calculus tremendously. Prof. Rez, any thoughts to add?
I just want to say that was epic. Those are my thoughts. Beautifully reasoned, Robbie.
All right, so if I may, can I give you the rest of the presentation here? Because I think actually the crux of the thinking comes a bit later in this case. So let me fill it out all the way through the chest x-ray as you have it, and then I'll tell you what happened with her. And then I'd like to have your thoughts on, the portion of the case that I would say really stymied me. So let's see, we have her past medical history, you have most of it there. In terms of the key medications that she was on, I would say methocarbamol, gabapentin, Risperdal, and I think it was duloxetine. All right, no pertinent family history. The social history, she's a former heavy smoker, quit maybe a month ago, no real alcohol use. She's fully independent at her baseline, and no drugs or anything else. No pertinent allergies to report, and I'll give you her exam. So on admission, she was febrile to 1011. The heart rate was 96. The blood pressure was 109/59. The respiratory rate was 19. And the pulse ox was, let's say, 93% on 4 liters of oxygen. In general, she was alert and awake, but maybe very mildly confused. She had some fatigue, some kind of generalized, or I should say, appeared overall ill. What do you have next there? She was, the HENT exam was unremarkable. The pupils were equal and reactive. The extraocular movements were intact, and the head appeared normal. Neck exam was unremarkable. The neck was supple. So then cardiovascular, also normal. Pulmonary exam by basilar Rawls. Abdominal exam, soft, non-tender, no organomegaly. And neurological exam, she had, well, you know what, the exam I have here is not very detailed, unfortunately, but she was alert and awake. No speech difficulties. She had cranial nerves that were intact, and she was moving all 4 extremities with equal power. No mention is made here of tone, but will be later. And her gait and reflexes were not tested. Skin did not exhibit a rash, and there was no lower extremity edema. On labs, on admission, her white count was 8 without any bands. The hemoglobin was 13, and the platelet count was 152. Chest X-ray showed, oh, I'm sorry, the chemistries were unremarkable, as were the LFTs. The chest X-ray, the EKG I don't have, it was unremarkable. The chest X-ray showed subtle bibasilar airspace disease. And her respiratory pathogen panel was positive for rhinovirus. So you can stop here and tell me what you make of her initial kind of presenting picture, and then I'll fill you in on what happened in her course in the next couple of days, kind of bringing us to the meat of the case.
All right, maybe I'll be brief here because it seems like we're gonna get much more data. I think something I noticed in the past medical history is these previous histories of pneumonia. To me, that's a red flag. And so, one, was she really having prior episodes of pneumonia? Or does she have some kind of mechanical obstruction leading to recurrent episodes of pneumonia? Or is there some form of immunodeficiency that has gone undiagnosed throughout her life, making her vulnerable to repeated episodes of pneumonia? With regard to the exam itself, nothing is too unusual. This is exactly what I would expect for someone with a pulmonary focus of infection. The mild confusion, like Robbie said, that can just be a bystander, the encephalopathy. So I'll be following that closely as I treat this patient with antimicrobials to see if it improves or not. Coming to the laboratory findings, it is quite odd that her white blood cell count isn't higher. I would have expected that with this degree of inflammation, but you can't put too much emphasis on one data point. I think the main question is, what do we make of this rhinovirus? Do we say this is all just a viral pathogen leading to the upper respiratory symptoms and the deeper respiratory tract infection? I think the answer to that is no, you don't say that, because rhinovirus, while any viral process can lead to a pneumonia, this patient is presenting quite sick. It's been going on for a whole week, so it's not short duration. The patient is hospitalized. So this is a patient I would treat for pneumonia, and depending on when she's last been in the hospital will dictate what type of antibiotics I use. So I'm getting a sputum culture, urine strep test, urine Legionella, and putting this patient on appropriate antimicrobial therapy. And again, reviewing a little more of that past medical history of pneumonia. Why is someone having so many bouts of pneumonia? Robbie, anything else you'd like to add before we get to the meat of this case?
No, I think that's absolutely superb. I recently learned that about 15% of patients with another alternate diagnosis of their infectious respiratory tract symptom have a positive respiratory viral panel. So I think you're seeing the tension that these PCR-based tests create, which is that they're incredibly sensitive, so sensitive that they pick up false positives. You'll see that story play out with stool PCR analyses where you have a patient with diarrhea who has 10 organisms that show up and you don't know which one is the cause. And you'll also see it play out in radiology where patients with back pain have MRI findings that are unrelated to the disease process. So recognize that at the end of the day, when you have great tests in terms of sensitivity, they mess up specificity. And I think that's the crux of Reza's analysis, is not that test is too good, that it picks up small unrelated viruses. A very good working hypothesis that I completely agree with. But I wanted to share that number. It happens in about 15% of patients, so not an insignificant time.
Robbie, that's so powerful. And that triggered another thought. So is this a false positive? Or we know patients who do get viral infections are at higher risk of bacterial superinfection. We see this with influenza and Staph aureus pneumonia. And the theory behind that is that the immune system, and this is just speculative, is so preoccupied with taking care of the virus that it is vulnerable in that state, making it at increased risk of a bacterial superinfection. So that's an interesting thought. Like, is it false positive? Is a patient more vulnerable to a bacterial superinfection? But I think we're both on the same page that we're not dismissing this as just rhinovirus because of the duration and the presentation. I think we lost the screen, folks.
Robbie, can you put me as host? I think Shema had a problem connection.
Oh, there you go. There you go. Okay. Thank you, Deborah.
All right, let us know when you want us to proceed.
You're good to go.
Right. Okay, great. So okay, and that's as Reza said, that's exactly what happened. You know, the patient was admitted, was started on antibiotics for initially ceftriaxone and azithromycin for community-acquired pneumonia. The rhinovirus result was noted, but not everything could entirely be attributed to rhinovirus. And then over the next 3 days, the patient developed the following symptoms. Her fever continued. It rose as high as 103 again, several occasions. She developed a bizarre affect. Her answers became inappropriate, and behaviorally she was odd. She was off from her baseline. For the fever, her antibiotics were brought into vancomycin and zosyn. Again, not exactly clear what was being covered, but the patient was febrile and out of concern for sepsis was being covered very broadly. She got some Lasix to treat what was suspected to be pulmonary edema due to her hypoxia. And her sodium dropped to 124. So ongoing fever, hyponatremia, and altered mental status were kind of the main things that were facing the team about 3 days after admission. I see Legionella being mentioned in the chat. Legionella was negative. She was seen by a psychiatry team. They thought that she had increased tone in her upper extremities. And they recommended that we stop the Risperdal and the duloxetine for the hyponatremia. And so there's two aliquots here. This will be the first of two.
Yeah, I think that this begets an important reflection about what it means when somebody is altered. So you could be loose in your description and say this person has altered mental status, but that term, when we use it in internal medicine, strictly refers really to level of arousal. So when somebody has a global encephalopathy or encephalitis, their level of engagement and arousal declines. But if you are more precise with the rendering of altered mental status, you'll be less vulnerable to mislabeling focal lesions in the brain as encephalopathy. So what can fool you? Focal frontal lobe disease can fool you and the person's personality changes, but rather, instead of labeling it as altered mental status, you say personality changes, which will trigger you to think, oh, this person may have frontal lobe disease. Similarly, when patients have changes in language or emotional expression, that might allow you to think of temporal lobe disease. And then if you extend that beyond to thinking about movement disorders, so here this person has stiffness and changes in their psychiatric phenotype, that is telling you that there might be a deep gray matter involvement or deep white matter involvement. So here, the patient seems to have maintained level of arousal with more specific signs of central nervous system dysfunction. So I wouldn't call this altered mental status. I would call this a likely focal neurological syndrome within the brain. And my ability to localize it is limited by my lack of expertise in it. But I would say that the combination of movement abnormalities and psychiatric changes are most evocative of a deep brain structure, either more likely gray matter than white matter. So what this means for me is I'm not too happy with the original hypothesis has to change now, and all of a sudden your yield of central nervous system analysis, be it through MRI or LP, has gone much, much higher. And I think that the exercise now begins with saying, is this a lung-brain syndrome? Or is this been a brain syndrome all along, complicated by aspiration that has fooled us into thinking that the lung disease is a distractor rather than a cause? So that's the tension. The brain is almost certainly involved in this disease process, which pushes you to say, is this lung plus brain, or forces you to reanalyze your working hypothesis as brain all along, with the lung being the sequelae of brain involvement. And I think that there are two other pieces of data to help you study that, the hyponatremia and the ongoing fevers. And for that, I'll pass the mic to Prof. Reds.
Wow. I just want to highlight what Robbie just did there, which I think was spectacular. One was, are we dealing with a process that can link both the brain and the lung? Or is this someone that has two independent processes, and either the brain process made the patient aspirate and develop pneumonia, or the patient actually has pneumonia, got antibiotics, it affected, serotonin or dopamine levels, leading to a drug effect like neuroleptic malignant syndrome. So it's just so fascinating to approach it from that lens. But what does this really mean for us, the provider? With regard to the hyponatremia, most likely this is SIADH, though there's probably a degree of hypovolemia. And the only way you make progress on that is by sending a urine osm, a urine sodium, and a serum uric acid. I think this patient is at risk for both. So, but you have to be so cautious, because when you treat the hypovolemia, that sodium might shoot up big time. And also, if someone has SIADH and you give them a lot of fluid, you can actually further worsen their sodium. So regardless of whether this is SIADH or hypovolemia, you just have to be cautious with managing the sodium. I think it would be a mistake to attribute the mentation to the hyponatremia, because usually with hyponatremia, when you get less than 125, you could start seeing some confusion, but this is not the case here, because we have other findings like increase in muscle tone and ongoing fever. So Robbie, what I would do here honestly is, one, I would look for drug-drug interactions, that is the antimicrobials that this patient was given, and the antidepressant, antipsychotics that the patient is on, to see if any of these can increase dopamine or serotonin, leading to a drug consequence. I still think this patient has a pneumonia, although there's no leukocytosis, there's crackles, there's hypoxemia, there is imaging finding of pneumonia. So I'm struggling to put the entire story together. I'm looking forward to the next aliquot, but I'm inclined to think that maybe it was like the pulmonary process that started, then a drug-drug interaction, and then the neuro presentation, or maybe like you said, or maybe an alternative lens is that it's all neuro leading to aspiration. But if it's all neuro and rigidity, it's hard for me beyond like NMS and serotonin syndrome, like to think about like rigid neurologic syndromes that may arise. I'd be interested in a CK here for sure. And yeah, and looking forward to the next aliquot of information, and can't wait to learn from our amazing presenters.
Can I just say one quick caveat that just crossed my mind, which is I'm really curious now that the syndrome is slipping beneath us, what the real time course is. Because I think this has happened a couple of times where you're like, I think this is acute. And now my mind, while you were reading, was like, oh, she quit smoking 1 month ago. Why is that? That's such a, that's an interesting, like people can quit smoking for many reasons, but one of them is like unrecognized illness. So now it's unclear to me what is actually going on. I'm also loose in terms of not where did it begin, what is, but also how long has it been going on for? So it's all melting away, Prof. Rez. Hopefully our friends here can help us a little bit.
Yeah, we can help. I have to say it was melting for me as well in real time when we were doing this. It was an acute process. Ultimately, the smoking was probably not related. But let me ask the group, either the two hosts or what do you want next? What test do you want next? Because we were stuck here in the middle. She was on Fengzosin, not doing very well, still febrile. Well, I can specify more. She was in and out of alertness, sometimes more oriented, sometimes less. Never comatose, or at least not at this point in the case. And then just had a very, very odd affect. Wouldn't answer your questions appropriately, gave inappropriate answers. I can't remember the details now. It was some time ago the case. So what do you folks want next? What tests?
Okay, do you want to engage the chat? Because people are putting stuff in the chat. Do you want to
From David, he says neuro-imaging. Oh yes, I see that. Yes, I agree with all of this. So I will give you, I agree with the neuro-imaging, and that is what was done. And then we did another test after that. So we did a CT of the brain. I can't remember if this was with or without contrast. I didn't write it down, but it showed that she had mild hydrocephalus. And we did a lumbar puncture at the same time, or around the same time. When we turned the patient to do the lumbar puncture, we noticed that she had a rash on her right buttock in a dermatomal distribution, which made us, well, I won't say anything else. It was a rash in a dermatomal distribution, which was vesicular in nature. We almost stopped the LP because we were concerned of going through the rash, but decided that it was far enough away from the midline that we could safely do it. We performed the LP, and these were the findings. The nucleated cell count was 151 with 11% polys, 77% lymphocytes. The protein was 188. And I just realized I didn't write down the glucose, but I'm going to say it was maybe 50. The opening pressure was normal. I will also add that at this point, her white blood cell count was 19,000 in the serum.
This is just so incredibly humbling. Prof. Raz, I think we should just dance. I'll share my spontaneous thoughts and pass the mic to you. Going into this, Reza made a compelling argument as to why this patient likely has SIADH. And if you use that as your anchoring hypothesis to say, I'm worried about an infection and I'm also worried about SIADH, three things should crop into your mind: zoster, TB, and Legionella. And we've already heard that Legionella, although the test is not perfect, is negative. If zoster is on your mind, if you're thinking infection plus SIADH, then seeing this rash on the buttock should make you even more concerned. But the tension with diagnosing any herpes virus-related infection is you're wondering, is it an epiphenomenon of the stress related to what else is going on, or is it the primary driver of the disease process? And that tension will linger until you search for an alternative cause. So what I will do with those hypotheses going into it is you can't ignore that the dermal rash is likely VZV, with the exception that you might be mischaracterizing HSV depending on where it actually is. And so going into that, I'll just analyze the hydrocephalus and leave the LP and the other stuff for Prof. Rez to analyze. So calling hydrocephalus on a CT scan is always a little bit tricky, especially when it's mild. And the first question is it communicating or non-communicating hydrocephalus? Which simply means that is there high pressure in the CSF? Are the ventricles dilated because there's an obstruction in them, or that the obstruction is actually microscopic in the subarachnoid granulations? And here, the lack of overt obstruction tells you you're probably dealing with communicating hydrocephalus, which, by the way, maps on fantastically to a meningeal irritation process. In fact, the DDX for non-communicating hydrocephalus does this person have a current meningeal insult, or did they have a meningeal insult before, like an old infection or old subarachnoid hemorrhage? So it latches on very well with the CSF findings. But if you use hydrocephalus to prioritize your infectious probabilities, it's much more compatible with tuberculous meningitis than it is with zoster. And the reason is because tuberculosis is a subacute meningitis, subacute to chronic meningitis that can cause enough inflammation to result in hydrocephalus. So that for me created a tension of saying, hey, could we just lock this all in and say zoster, or should we be careful and wonder TB? But there's a lot more data to analyze, and for that, I'll pass the mic to Prof. Rez.
Amazing, Robbie. I'm really humbled here, and this is how medicine is. Like, there's no reason that this patient at time point 0 needed a thorough skin exam. And it also tells you how challenging it is to get an accurate diagnosis in someone who, because of encephalopathy or because of some circumstances, unable to convey a history, because that rash is probably painful. And someone would point to it, and then you would look as the clinician. But the answer isn't to look at this case and say, oh, we should examine everybody head to toe. No, the exam and the history should really be hypothesis driven. The only time you deviate from that is if someone can't really convey an HPI, a history. But here we had a really good explanation for this patient's presentation: fever, hypoxemia, crackles, prior URI symptoms. No, so I don't think there was a delay in diagnosis. I'm interested to hear from the presenters how they perform their reflections in cognitive autopsy, but I could see myself going down the same path. Now where we are is looking at this CSF. You would frame this as a lymphocytic pleocytosis, which has a broad DDX, but we have to look at it through the lens of this particular rash. So likely it's a herpes virus, and that would cause an elevated protein that would cause a lymphocytic pleocytosis. To Robbie's point, open to other infections, and we'll probably send for those. But I think what's most important is getting the PCR for the herpes viruses, particularly HSV and VZV. But then you have to step back and ask the question, does this patient have VZV pneumonitis? I mean, I don't think so. I think that Robbie's hypothesis of this patient being stressed, then reactivating, that reactivation then, bleeding into the CNS and causing encephalitis, more so than meningitis by, looking at her sort of confused status, encephalitis. So I would treat her for VZV meningoencephalitis, but I would continue to treat for a pneumonia of bacterial etiology. Now I'm getting beyond like my comfort zone. So I'm interested to hear from the presenters and to also read more about VZV.
All right, let me just, thank you to both hosts. I want to see if there's anything in the chat. People were asking us where the patient was from. The patient was from the state of Rhode Island. Gram stain on the CSF was negative. And let's see. The questions about the meds, do we know if she was using the methocarbamol or gabapentin 4? We really didn't, and she couldn't provide a good history for us on that, unfortunately. We didn't think it was med related necessarily initially. And then someone asked for an MRI that was obtained, and it showed, just as Dr. Geha was saying, no evidence of obstruction. So the same findings as the CT brain, the mild hydrocephalus. And then I have to apologize to the hosts. I brought you a tough one with 2 misdirections. I'm sorry, but this is how it happened in real life. So you could not, if you saw me in that room, Robbie, I'm sure remembers on 3 East, when I turned the patient over and I said to myself, oh my goodness, this is VZV, of course. But that's not what it turned out to be. The CSF cultures grew listeria. She had listerial meningitis. And, oh yeah, I was supposed to say, this is the aliquot that reveals the case. This is the aliquot that reveals the case. She wound up having listerial meningitis and was treated with ampicillin for, I don't know, a couple of weeks intravenously, and her symptoms completely resolved. And she was able to leave the hospital to go to rehab. And so for me, I mean, the host can comment, but for me, the teaching point from this case, it's actually interesting. Someone, Terry Milanakis, who's the head of ID here, before he was the head of ID, did a study on listerial meningitis. And it turns out that the mean time to diagnosis for patients with listerial meningitis, mean hospital day, is 7. And that's about how long it took us to figure out this case as well. So it's a subtle one. And it, you know, for me, I wish that we had taken Robbie's and Reza's approach earlier and kind of focused in on the CNS and did that CT and did that LP earlier, having taken all the signs here of the confusion, the hyponatremia, and really zeroed in on the CSF, but whatever it was that was causing the problem there. But I wish we hadn't waited for the patient to really start to decompensate neurologically before we went there. So that's kind of my takeaway.
Well, you know, geez, I think it's amazing what happens when you put it out there and you name the final diagnosis. You're like, oh my gosh, there are very few bacterial causes of myalgias and arthralgias, and listeria is definitely on that list. It was such a prominent part of a recent NEJM case with listeria as a diagnosis. And then you say that you know, there's a respiratory component and a CNS component. It screams at you. But thinking of it beforehand, it didn't even cross my mind, honestly. Even though when you ask yourself, what are the most common causes of acute bacterial meningitis? It's in an older adult. It's certainly up there as number 2 or 3. So you know, my reflection, I think, is geez, sometimes the journey to a diagnosis like listeria is one in which the base rate is such a profound argument against it, because the most common cause of confusion and fever is an extracranial disease process unmasking cranial vulnerability. And so, geez, I think if we ended up LPing everyone who presented with her initial chief concerns, we would probably be LPing 100 times more often than we are right now. So for me, I'm trying to like ask myself, what are really the powerful clues that would push you to do things earlier? And it's increasingly being exposed to the effort to try to grow myself in saying, what is altered mental status medically, or change in level of arousal, and what are all these other things? All these other things are not necessarily altered mental status. And I think for me, I've had so much unlearning to do to call, hey, this person is answering my questions in an unusual way, not to call that altered mental status, call that an encephalopathy with focal features. And I'll just add on that the reason it gets confusing, and the reason we often go back to our original training, is because there's patients with dementia who get confused in this way. But remember, you have an explanation for why they have focal features, is they have an underlying tauopathy or another explanation for their focal findings. So her at 64, she probably has no underlying reason for those kind of very specific behavioral dysfunctions. So it's so hard in real life, but for me, the growth will come from yet another case emphasizing what has been a journey for me to say, what is altered mental status and what are focal brain signs? And I'll probably fail many more times before I consistently get it right. Prof. Rez?
Wow, I first of all, I just want to thank the presenters for bringing such an extraordinary case, because it's like bread and butter medicine with twists, and this is reality. So thank you so much for bringing this case. And I agree that I think knowing that mild confusion is okay, but that you keep following that, because if that ends up being the center of gravity, then you start thinking about an MRI, LP, and EEG. And man, I prematurely closed definitely on the VZV, and like making sure to send, the broad scope culture and the routine stuff on CSF. So I thank you so much for bringing this case. You definitely stretched my ability, and because of it, I'm going to grow. So thank you.
Well, we are the birthplace of one Dr. Geha. We had to come strong. We couldn't. We had to represent.
Truly, I think I'll never forget this case. We never will. And I think if I ever thought that my gratitude to the incredible high quality, both personal and professional experiences at Miriam Hospital, here we are like 10 years later getting that reinforced. So really thank you guys for an incredible presentation. And also just, I think what stuck with me beyond the medical stuff is just how personal it was for you and how you shared your ups and downs and being earnest about I think what is an inherently complicated case with an inherent delay in it is a treat, and I think reflects the incredible people at this incredible institution. So thank you. And I mean, what more reason do you all have to check out the Brown Journal of Hospital Medicine than a topsy-turvy case like this that you can consume on your own time? So thank you all. Really, really appreciate it.
Thank you for having us.
Thank you so much.
All right, Rafa, take us home with the teaching points, please.
First, thank you, case presenters. It was incredible and very entertaining case. I learned so much from that. Thank you, Rabbi. Thank you, Reza. Thank you, everyone who joined us today. So we started the case with fever, cough, and sore throat, and then Reza reminded that fever relates to inflammation. Tempo is really important here. So when you think about acute causes of fever, think about infection to prove it otherwise. You have to remember other causes of fever as well. You can use the IMA mnemonic. Besides infection, you could think about a malignancy, drugs, and the gluconeopathy. When it comes to the sore throat, we thought about pharyngitis. Less likely in this case should be due to, for example, Streptococcus pyogenes due to the age and cough. Shout out to the Central Criteria, Uncle Bob, because, greater than 44 years old. Older than that, you actually take a point from the patients. So when it comes to the chills and dizziness that the patient presented, we thought that the dyspnea, 95% of the causes are cardiopulmonary related, but remember other causes as well, like anemia, deconditioning, hypothyroidism, obesity, neuromuscular weakness, acidosis, anxiety. We didn't expect this to be a benign disease since we thought about the chills, it can be translated into bacteremia. We also thought about, for example, pharyngitis complications, or maybe a primary respiratory tract disease leading to that. When it comes to recurrent pneumonia episodes, it's very good to remember that if it's affecting the same lobe or different lobes, because you have different diagnoses for that. If it's the same lobe, we could think about a bronchial obstruction, like Reza reminded us. For example, if it's intrinsic in the case of a cancer, intrinsic in the case of a bronchiectasis. If it's recurrent aspiration, you could also see that, for example, GERD, poor dental hygiene, neurological disorders. If there are different lobes with recurrent pneumonia episodes, you could think about immunodeficiency or non-infectious vasculitis, cystic fibrosis. And when we thought about the altered mental status that this patient presented, we thought about the mnemonic mist, metabolic infection, structure, like severe hematoma, but also trauma. But then Rabbi reminded that focal neurological deficits can fuel you. So for example, in the case of frontal lobe disease, you could see personality changes. In temporal lobe impairment, you could see language disorders. And we saw that this patient had a vesicular dermatomal distribution. You could think about VZV or HSCV, depending on the location. And finally, this patient was diagnosed with Listeria meningitis. And apparel that shared by the person that the meantime, the diagnosis is actually day 7. You could think about Listeria besides the meningitis leading to arthralgia, gastroenteritis, and infants leading to granulomatosis infantiseptica, and the treatment is ampicillin. So thank you, everyone. Hope everyone had a nice day.
Rafa, before we end, I just want to say two quick comments. One is, Robbie, have you realized that the teachers that are doing the teaching point here, Rafa, a couple of weeks ago, someone else, they actually add like improved teaching points to the ones that we're making. And to give you a specific example, this recurrent pneumonia episodes, to break it down into the same lobe or different lobes, I never thought of that, but that is brilliant, Rafa. Terrific job. And then the other comment I want to make is that I know we lost Shema probably due to internet issues, but this just speaks to the team of CP Solvers VMR that Deborah just jumped in and we took off as if nothing had happened. Like, to me, that's just so impressive. And I'm not as closely tied with VMR as you are, Robbie, but the team that is there is just incredible. So a huge shout out to the team, huge shout out to Rafa. And yeah, Robbie, any thoughts on that before we go?
I think you said it better. It's like it's all about the people here. You know, the medicine is great and what brings us all together. But I think what makes VMR special is just the people. It's all one big happy family is seamlessly working together to try to learn and grow and take care of patients better. And I think the real emphasis is also the fact that you see that and celebrate that. And the only thing I have to add on top of it is how incredible you are to see it and recognize it and call it out. And yes, Arkady, this is all, and Vijay, this is always a love fest. This is what we do every single time, is douse each other with love. So we hope we see you all next time too. Feel free to let us know whenever you want to come on and hang out and tell us another case, or jump on in and be part of the audience.
Well, we very much appreciate you having us.
Bye.